that when I'm at that clinic, I ask them and I opt in and they send it? Or do I go to you first and then somehow take my eggs that look good from you back to that clinic? What is this process? Because it seems like there's a gap in the conversation.
You go to the clinic.
And then I ask them specifically to send it to you, and I pay them directly for this to go to you. Yeah. And this is a standard option at all of these clinics. It's just maybe not known about? Or do I have to find a certain clinic that does do that already, that's on your list or something?
As I said, we work with almost half of the clinics in the US, and there are other labs that work with the rest. So all clinics probably have one lab, and some have the lab inside. So I think it's readily available. It's just that some doctors, for instance, for younger patients, it's not the standard of care yet to offer it. That doesn't mean that it doesn't work. I think it does work, and as Dr. Sills demonstrated, it does work. And it could be recommended to everybody, but it still hasn't reached the level that everybody's doing it. So maybe you have to ask. But for others, let's say recurrent miscarriage, advanced maternal age, most doctors would talk about it with you and recommend it or give you the option.
Maybe this will help a little bit. So when it's determined that you would benefit from in vitro fertilization, and that maybe in the course of the evaluation of the couple, let's say it's discovered that maybe you had a miscarriage in the past, and it was due, the products of that conception were analyzed, and it was discovered that it was due to a chromosomal abnormality. And frankly, that happens a lot in miscarriages. So if they find that, the clinic may say, you know, there is a pretty good correlation with, if this happens, that it could happen again. So let's try to prevent that. Let's also do pre-implantation genetic screening or diagnosis to make sure it doesn't happen. So you go through your in vitro try, which means you get a bunch of these injections, and then the eggs come out. The eggs are converted into these pre-implantation embryos in the laboratory. By about the 5th day of development, there are about 100 cells. We take just a few of those cells off, and actually, even by that time, we know that the cells we're taking are not the cells that are going to ultimately become the baby. They're going to become the placenta, other aspects of the fetal placental unit. So we snip off a little piece, and we send that biopsied material to testing laboratories such as Dr. Munne's. Takes them overnight to give us the answer, which comes back to us on a secure portal on the internet. And they'll say embryo number 1 is a female and normal. Embryo number 2 is a boy, not normal. Embryo number 4, and so and so and so, depending on however many embryos that you have. And we can either put them back, the ones that we now know are normal. We can do a fresh embryo transfer that following day, or what is gaining a lot of ground now is with the advent of what we call flash freezing or vitrification. It's a very, very effective way of freezing embryos. Embryo really doesn't even know it's been frozen. And so we then tell the patient after the biopsy, you go home, we'll get your results, and we'll find the results, and then you come back on a cycle that is not the one that we took the eggs out, because we're finding that there's a lot of stuff going on physiologically with you. Your estradiol levels are up here, and some of that stuff actually is not so great for the endometrial lining. And so we have you come back when that on a non-stimulated cycle where everything is calmed down, and all other things being equal, the pregnancy rates are actually higher with these thawed, determined embryos to be normal by this stuff that's called CGH. So that's kind of where we're at. Just so maybe everybody in here knew all of that, but if you didn't, that's the way it's done. So I see on our time thing that we've got, I think there's some online, Facebook, Twitter.
No, not at this time.
Not at this time.
I have a question, though, I'd like to ask. And thank you for that extra explanation. I appreciate that myself. I'm curious, the factor that I'm going to use the word quality of the eggs goes down with maternal age, right? What is that about? Like, let's say the person takes really great care of themselves, right? Woman A is 45, and look at her. She looks like she's 20. She's running around. She's got a lot of energy. She eats great food, organic, everything. Woman B, 45, eats at McDonald's every day. Like, you could say she's aging 45B, and 45A isn't aging the same way. So wouldn't it stand to reason that 45A's eggs would be in better shape than 45B's eggs? Or is it not about that? Because it's just like this whole thing, maternal age, eggs go down, the end.
Maybe I can give the first shot at it, and because that's a complicated issue, and then the other speakers can probably chime in. But that's a real. What you mentioned is very important because people come into us and say, "Look, I'm in great shape, and therefore I must have good eggs," and that's really not true at all. The truth of the matter is some of these chromosomal abnormalities in terms of trisomy 3, monosomy 1, a misconnection, if you will, of the absolute number of a certain gene pair, is a complicated issue. But essentially, when an egg is mature, then those two pairs of chromosomes have to split and go to opposite sides as the egg gets rid of some of the chromosomes to allow the sperm in. And that's driven by these little microfilaments that pull the chromosomes to the sides, and maybe the guys will be a little more specific in a moment. But DNA is very sticky. So when those filaments break down as the egg ages, then those two pair can be pulled to the wrong side, or they can be pulled in abnormal directions. And that's an aging issue. Now on top of that, the genes that control those chromosomes to split and separate is also driven by machinery that pulls these microfilaments to the sides, and that's driven by FSH. That's a hormone. So here again you see this link between hormones and chromosomes coming together. We're struggling with that all of the time because, as many people know in the crowd, when people get older and they're undergoing stimulations, we're giving them more and more amounts of FSH to drive those follicles. And yet we know that's interacting with some of the machinery that controls the separation of these chromosomes. So the truth of the matter is, at this point in time, there's not a lot we can do about it, other than take those embryos and figure out which ones are chromosomally balanced or not. In the future, whether we can control that all remains to be determined.
So what you're saying is nothing has been researched about how to improve the filament function, if I'm hearing the words correctly, that is separating the DNA opening, right?
Well, no, I'm not saying that. I'm saying a tremendous amount of work is being done in research in that area. But effectively, at this point in time, as of 2013, what Dr. Sills and Dr. Hill and Dr. Munne are talking about in terms of saying, okay, we can't necessarily control that yet, but we can take those embryos and figure out which ones did it right and which ones did it wrong, and screen and select. Maybe 5 years, maybe 10 years from now, we'll figure that out. And I can give you an example. There's somebody named Bob Casper in Canada that's taking this on a metabolic level and saying, well, maybe the energy utilization to separate these things needs to be improved because that's driven by mitochondria in those cells. And maybe we can kind of pump up the energy utilization and try and improve that, but that's all theoretical, although he's doing a study on that. So there are some opportunities, but right now what the speakers are saying is really what we have at our disposal.
And the growth hormone that was mentioned earlier for the older mothers, is that what it's going towards, that particular function?
Not particularly. The growth hormone is really looking at an issue we aren't even talking about, and that is the cytoplasm of the egg, because the egg has the genes in the middle, and the cytoplasm is what holds the energy organelles around it. The growth hormone and other hormones are looking at energy utilization of the cytoplasm, and that's really not what we're talking about. We're talking about the genes in the middle of the egg.
We have a question over.
So, if I understand correctly, so basically you have a new process for filtering embryos, right? A way of finding the best of the best. Isn't that going to make it more rare that you find the best of the best? Doesn't that actually reduce the number of potential embryos that are out there in the world? Because you're basically eliminating all the ones that were maybes that people are using right now, and creating a field of just, we know these are all really good, but it's potentially a much smaller field. So they'll become more rare, become more expensive, and harder for people to get pregnant in the long run?
Let's look at it another way. Mother Nature, call it Mother Nature, call it wisdom of the body, whatever you want to call it, but if you have a couple that doesn't have any fertility issues, and they fall in love, they get married, and they want to have a baby, they actually only have about a 25% chance of it working every month. And that's not because she's not releasing an egg, and it's not because a sperm isn't finding the egg and fertilizing it, but things happen. And they just don't happen with perfect fidelity, and they, even under the ideal conditions of, and they're in their 20s, and he has an Olympian sperm count, and she ovulates like a clock, but the fact of the matter is that human beings are just built this way, that only about 25%. So this is why, after a year of trying, okay, if you're not pregnant, you really need to go and see somebody like these two gentlemen to my left, because fertility specialists can very quickly, with a few tests, home in on what's going on. Now, to your question about, well, if you're screening the embryos, you start out with a whole bunch from a patient, let's say 10, and depending on her age, and really, the chromosomal issues are oftentimes, pretty much the majority of the time, they're coming from the egg and not the sperm, and there's reasons for that. I know it's not fair, but it's the way it is. All we're doing is we're just doing what nature's done, and we're just going, okay, well, this one's good because we've screened it, and then we put that one back, and the odds of pregnancy, of course, go up, and the chances of miscarrying go down because we know what we're putting back.
David, can I make a point?
Please.
For some of us who are maybe older in the field, when
That would be us.
some of us more than others, when we first started many years ago, we didn't have these wonderful capabilities to grow the embryos out and check them, and that was just unknown. So what happened was, as soon as we made embryos, we froze them right away, immediately, almost, at the pronuclear stage. Well, what that did is that caused a stockpile of extra embryos that we know we would have never used now in today's time. And what happened, and it wasn't too uncommon for people to have 15, 20 embryos frozen, and then every month you would go in and you would play all of these hormones and then transfer a couple, and that wouldn't work, and then another month you'd do some more. And it took forever. And the success rates were low, the expense was high, and the emotional trauma, which we haven't even talked about, was astronomical.
Huge.
So as we've moved forward in this field, and the gene people have gotten in here and really taken a very close look at this, it's really the efficiency of the process, because when people come in, the average age of our patient in our practice is about 36, and that's very common for most practices. People don't have time anymore, and they want to move on. So some of these things are a cost-benefit ratio. That's what's really the stumbling block. Is it really of value to do this? But I don't think anybody's being critical that these aren't wonderful things to do, so that you make the practice as efficient as possible for the couple. That's what it's all about.
We have a burning question here.
Go ahead.
I just have one question. What are the chances that doing a PGD will damage the embryo cells?
So there has been now, I think, a quite definite study showing that if you do the biopsy on day 5 at the blastocyst stage, which there are about 150 cells or more, you are doing the biopsy on a layer of the embryo that will become the placenta. So that's a much better way of doing the biopsy than when we were doing it on day 3. On day 3 now there are some studies that there could have been some damage when you were doing at the 8-cell stage. There were only 8 cells, and they haven't been differentiated yet into different layers. Now that we are doing it a much later stage, not much later, 2 days more, but it's a there are already 2 layers of tissue, and one is going to become the placenta. So it's like a very early prenatal diagnosis. You're taking cells from it will become the placenta, not the fetus. So really, you're not touching the fetus. And the latest studies show that there is actually no effect, and at the contrary, we are improving results. So
we biopsy hundreds of these embryos every month in our program, and it just doesn't happen. It just doesn't. It's extremely rare. If an embryo is biopsied and the embryo doesn't make it after that, there was something really wrong with the embryo. It's really, once the technique has been worked out, and it's worked out now, that it really is almost a non-existent thing, that the embryo is damaged by the biopsy procedure itself.
Have you found any risks for the embryo itself in the long run, long-term side effects once the healthy child...
Take a little piece of it off and it comes out missing a foot or something like that? No, the answer is no. There have been studies, it's been around now a pretty long time, and there doesn't really seem to be anything like that. Certainly, I'm being facetious about missing a part of the body, but, could it affect intelligence? Could it affect, something? And we've yet to see it. There's a lot of IVF that's done in the world now. In fact, I think it's estimated in the United States that something like 1% to 2% of the population now is being added to by assisted reproductive technology. And the number is even higher in Europe, where they do, there's almost twice as much, maybe more, 3 times as much IVF that's done. We're always looking for subpopulations within patients that have IVF to see, are there groups that you see a higher incidence of birth defects and things like that. The risk involved in IVF and any of the ancillary things that we may have to do for certain patients is certainly not zero. But there's always that risk benefit. But overall, it's a pretty safe practice, what we see. Okay, so is it Twitter time, or one more? Somebody, I see a few hands. Yes, ma'am.
I just had a question on gender. You had said earlier you can determine which embryo is male or female. Do you have a lot of clients that are requesting gender selection? Because I know that's a new hot designer thing. So
that does come up occasionally. It's not something that our program advertises, but it is something that is deeply important to my patients. And I think my consults take about an hour, so I talk a lot. So I typically cover the fact that whenever you get the report card, so to speak, of the embryo, as Dr. Hill said, one of the pieces of information that you glean from array CGH is embryo sex. That's going to be part of the quotient of the data that is delivered from our laboratory colleagues. So if they have an agenda about what they want to have transferred, I say, if you would like us to control which of this panel of embryos that have checked out as being chromosomally normal, please let me know. And I think that's the opportunity for them to say, well, we'd like, if it's all the same to you, Doc, how about we just transfer embryos number 3 and 4, or maybe just embryo number 1. So I think there's been a lot written about elective embryo sex selection, the ethical luggage that accompanies that debate is extensive, and it's been unpacked by lots of authors in Europe and in America. I think that's still very contentious, but we could have a whole panel just on that topic probably to fully develop it. But you're right, the point you're making is exactly valid. It is something that is knowable. That's something that was knowable from the earlier FISH applications of the earliest days of PGD. So just to be fair, it's not something that's a unique advancement that's peculiar to array CGH, but it is part of the array CGH package of information.
thank you.
Yep, I see something. I see the light flashing away at me here.
ask one more question? Because I think one thing that's confusing to us sometimes is understanding genetics when we're a carrier versus there's a chromosomal error. And from what I understand, you will be able to tell either way what's going on. But I understood you to say that when there is a chromosomal error, as opposed to you being a genetic carrier for something, that is likely to repeat as well. And so I became a little bit confused, and maybe I just don't understand, the filament's creating the chromosomal error versus I'm a genetic carrier for something.
You're right. Two different things. Let Dr. Munne handle that.
Yes, so there are two mechanisms in which you could have a baby that it's abnormal. One is they are inherited, so the couple is carrying each one of them the same genetic abnormality, although they could be perfectly normal. But if the two chromosomes or the two genes that are abnormal, they go to the same embryo, then you have an affected baby. Or it could happen that just the egg, because of aging and other factors, the chromosomes get misaligned, and then you would produce an abnormal embryo that is chromosomally abnormal. So two different things, but we use the same techniques, or different techniques, but the same method more or less to detect both of them. Right now, we need to know in advance if the couple is carrier of a genetic disease in order to look for them, because we can only look right now at a few genetic diseases at the same time in the embryo. For chromosomal abnormalities, we don't need to know. We can look at all of them. But for gene defects, we need to know specifically which ones to look for. That's why we want the couple to be tested, because otherwise we cannot do it. In the future, and probably in a couple of years, that won't be necessary, and we'll be able to check at the embryos directly. But right now, we still need to know if the couple has some genetic disease to be able to test it.
And I understood that you could do both, figure out
yeah,
if
we
there's
could
a
do both
chromosomal.
at the same time.
But what I didn't understand...
We still need to know what to look for. So you have to tell us, or we have to screen the couple to see if they have any genetic defects.
For the carrier part.
Yeah.
But with the chromosomal abnormality, you said that if that happens once, that there's very high likelihood that happens a lot or will happen again?
Yeah, that you have a higher chance of having more chromosomal abnormalities in the embryos. So for those, we don't need to test the couple. We just need to test the embryos.
Okay. Right. Thank you, gentlemen.
Thank you.
Thank you.